But at this particular stage, I would like to ask the two speakers, Emily and Martin, to switch on their cameras and come back so we can start the discussion. I'm sure we will be able to look at some of the aspects even that Hans has mentioned as to how we will deal with them. And if there are a few questions that I can see coming up, I shall start with it. So when the questions are asked, I think Emily and Martin, two good talks. Thank you. I enjoyed both of them. They were brilliant talks. And you can see that there are very many similarities between what Emily said and Martin said. The practices are there, the standards are there, the concerns are there, the human factor issue is there. All these questions are there. But shall we just ask the questions that have come up here? Then I have a few questions for you too, and we'll start the discussion. You may both answer the questions. There is one particular suggestion by Corina Matt, who says the use of easily readable large lettered name badges for all members of the team to improve communication, particularly in adverse events, is very helpful. So it's probably something they do in their hospital. So should it be in the recommendations? So Emily, would you like to answer that? I don't know your practice in LA. Do you actually have name badges to say who is who?
So we do have name badges. Unfortunately, the print is very small. I think in the patient safety community, and especially on social media, this has been talked about a lot in terms of identification of who you are, especially in the setting of an emergency, can be very helpful. So to kind of extrapolate on that, there's something that has been tried, particularly in Australia and New Zealand, called the Scrub Cap Challenge, which is basically you put your name and your role, basically anesthetist, anesthesiologist, medical student, or whoever, on your scrub cap, so it's immediately apparent to everyone who you are. And in my department, we actually just recently received our scrub caps with our name and our role on them. So we are actually trying it in my department. So that might be also helpful as well.
I think Martin can answer that question quite easily. Martin.
Yeah, similarly at Coventry, we also have embroidered scrub hats with our name on them. And since the introduction of them, I've learned so many people's names that I've been working with for a long period of time, but just never exactly knew the name. There's Krish's hat there.
My hat there. So we got that. So we all there, which is good. Good thing. It was an infection control issue for some time, wasn't it, Martin? Then we have it washed, cleaned, a few of them, make sure it's not soiled. Yeah, go ahead, Martin.
Another thing that was very useful, particularly during COVID ITU times, is we had really large stickers which were colour-coded, which just had our job role on them. And when everybody was wearing scrubs, PPE, everybody looked like they could potentially have the same role. Having a massive sticker that said anaesthetist or ODP was incredibly useful. And some hospitals in the country use those for trauma call situations, and there's obviously lots of use in there.
Yeah. Another thing, Emily, you might have heard Martin mention ODP. Are you familiar with this, operating department personnel? Because in America, you don't have ODPs.
I guess what are ODPs? Like, what do they encompass? Or who do they encompass?
ODPs are operating department personnel. We have a regulation that we actually do not do any anesthetic without an ODP being available. They are very trained staff. They are like nurses who are trained in anesthesia. They are very good at checking the machine, setting up that. They know about the patients. They know what an anesthetist would need. So they would set up all the equipment that we would need, and they are fully trained to provide things like cricoid pressure or manage a crisis. So they are basically our right arm. Sometimes people have used the term co-pilots to describe ODPs in the UK. I know I have, from my experience in America, we do not have ODPs, which makes the situation more complex for you, I think.
Yes, no, definitely not. We do have nurses that are helping us in the OR and in the non-operating room setting, but they're not specifically trained in helping anesthesia. So that would be immensely helpful if we had that here.
Yeah, so how does your setup start? Do you have to go a couple of hours early and start setting up things, because you have to do everything from scratch?
We have to do everything from scratch. We do have technicians that help us bring, our anesthesia equipment there and help us kind of set it up, but they don't necessarily set up our airway equipment or draw our medications or know anything about the patients. All of that we have to do ourselves.
Yeah. Do you use any special monitoring, or is it just a standard monitoring?
We use standard monitoring for all of our cases as much as we can. There are some of our non-operating room locations when there is no anesthesia machine available. So in those cases, we kind of rely on our end tidal, but otherwise we also have standard monitors for those cases as well.
Yeah. There is a compliment for you, Martin, from Chloe Fairbairns, who says, Martin, great talk, thanks. Have you found that you have uncovered a lot of unmet need by setting up a service for GA scans? I wonder how many people have just not had scans they needed in the past.
To streamline the process just makes it a lot more straightforward and just improve access to these facilities. More often than not, the reason we offer GA scans are for patients who can't possibly have a scan without a GA. So patients with complex learning needs, patients with movement disorders, chronic pain disorders, etc., which preclude them lying flat. We don't tend to offer it purely for severe claustrophobia because of the capacity issues, but if a patient with severe claustrophobia does need a scan and an MDT agree that that's the only way of moving forwards with their care, then we will provide that service. So yeah, it has kind of opened the door to a kind of a barrage of requests which do have to be triaged, because it is a very valuable resource. I find it very interesting listening to Emily's talk about the percentage of theatre versus non-theatre anaesthesia which occurs in America. We just do a fraction of it. I always think of the patient who needs a joint injection. If they're admitted under orthopedics, then they're just slotted onto a list to have it under general anaesthesia or sedation if necessary. If they're admitted under rheumatology, they practically have no chance of having sedation or general anaesthesia without huge advocacy from the rheumatologists and a long planning process. So it really does differ. Two patients with the same condition presenting via different pathways can have very different treatment outcomes. Yeah.
Emily, it was nice to hear you mention Remimazole, which is something UK is catching up with. There are some hospitals that are using Remimazole. It is, but I think, Martin, what do you think about that?
I think it's a fascinating innovation. I'd really like to get some experience of using it or talk to people who have used it, but it's not something we have in our practice. As with NHS cost funding, new drugs are often difficult to be implemented on a wide scale.
There is an attempt to introduce it in our hospital as well currently, which will be nice. I'm sure many hospitals are trying to look at Remimazole as that. Another question I wanted to ask you is about your team briefing before you start and all that has to go on. How effective is it in a noisy environment? Where does it happen as effectively as it happens in theaters? Emily?
Is that for me? Yes, so we do have a standardized team briefing where we go over the case, what the specific procedural steps are, important medications that are needed. We do require our proceduralists and our nurses and our technicians to be there. Unfortunately, as is often the case at the busy hospital, sometimes the supervising or the attending radiologist cannot necessarily be there. So sometimes that can introduce a little bit of variability in the briefing. What we have found, though, I think, is that although the briefing has been very useful for procedure-specific steps, very often patient comorbidities or underlying medical conditions are not necessarily fully appreciated by our proceduralist colleagues, whether they are interventional radiologists or gastroenterologists. These are conditions that could potentially interfere with the anesthetic plan, and that does require some more discussions prior to the patient being in the room or even before the day starts. So we are working on better means to communicate preoperative optimization needs to our procedural colleagues that need to take place well before the patient gets to the hospital.
Yeah, Martin, how is our situation here?
Very similar, really. I think one of the big issues with regards to the World Health Organization checklists is that they're so heavily modified between the two different areas that both teams more or less have to do their own checklists sometimes simultaneously. So merging paperwork is a really important step forwards to ensure that the right things are asked at the right time. I think what's really useful, particularly on an elective list, is the team huddle at the start, where everyone can be present and you can virtually walk through the entire day. And sometimes we spend 10-15 minutes doing a huddle for an interventional radiologist to make it exactly clear what's going to happen in each of the cases. And everything spelled out from the start allows people to be prepared, get additional equipment, additional resources, etc. So I think a really well thought out team huddle at the start of the day is vital for these cases.
It's vital, yeah. And I think also a debrief is often something that we should do, but unfortunately, most of the time, in my personal experience, debrief doesn't happen as effectively as it should do, because people are already trying to go away. But I think debriefing is an essential component of this as well. I think we have a list where a nurse will say, let's have a debrief, anything to report, any equipment that is not working, any learning points from the day that gets passed on for the next day, which is useful to have. There is one more question. This is from Anthony Cartwright. This is about many hospitals have NORA services in the same building with familiar equipment. Do you feel that if you had a remote building on the same site, you should have a complete and separate anesthesia equipment and medication provision as per the OR to support the service, even if MAC or procedural sedation provision is offered? I think you have in a way answered that, Martin, in your talk, that you do have an anesthetic machine, whereas we do have situations where we do not have the full equipment. So I think the question is whether every NORA setup should have the same setup as an OR. Any of you can answer. What do you think, Emily?
I think sometimes it's impossible to have the same setup. Here in the US, we have situations where people are providing anesthesia in dental offices. So I do think it's important to keep up your standards of safety, making sure that you have monitoring equipment available, emergency equipment available, means of ambu-bagging and ventilating the patient as much as possible. And I will also refer that commenter to the APSF guidelines that I mentioned in my talk that were just recently published in ANA, which does try to be inclusive of both inpatient and outpatient settings for NORA.
Excellent. Yeah. And one thing common that both Emily and Martin were talking about was the ergonomics. And it is interesting because I have been part of ergonomics, and the Association of Anesthetists has published the guidelines only a year ago. If you want, I can forward that, Emily. I don't know if you have had an opportunity to see that. It's quite comprehensive, and you highlighted all the problems that we face. One of the common things is we anesthesiologists are hardly contacted or discussed with before they plan a setup. And we are often excluded. We often walk into the situation and start the anesthetic with whatever we are given, which makes the life so very difficult. And it is the same even in operating rooms. But when it comes to non-operating room anesthesia, that makes it a lot more challenging. And if it is a new theater, I'm not sure whether Martin and Emily, whether you had an opportunity where people were actually trying to contact you and see what can we do different here. I think there's no attempt to contact the anesthesiologist. Is that correct?
Yeah.
I will say before, maybe about a decade or so ago, there really was no concerted efforts to contact the anesthesia department in the planning of these areas. But recently, in the past 5 years, we have worked on constructing new areas in the cardiac cath lab and also in the hybrid OR, and as well as interventional radiology, where our department was intimately involved because we said we needed to be intimately involved because we're providing care in these areas. And that has really improved the ergonomics of the situation, like providing enough space for the anesthesia machine, the medication dispensing cabinet. So we've really had a role in making those decisions in the past couple of years.
That's a good development. That's good. Martin, I think in the new theaters that are being made in our trust, we have been contacted. There has been a great input from the anesthesiologist as to how it should be designed. So the future of safety, of course, for safe anesthesia provision is the discussion with the whole team, everyone involved should, including perhaps the patients, as to what they like to see in an operating tube, because we often in a team setup, we forget the involvement of the patients. They should also be given an opportunity to discuss what they like to see. So I think that's fantastic. I'm very pleased you're here to do the talk. Hands on, I will take the questions. And just one word from about each of you, Emily and Martin, about what you thought about Hans' presentations of going up to the top of the mountains or the roadside, provide anesthesia care under most complex situations. Well, what that would be, I think my heart would be racing when I'm doing something like that. What do you think, Emily? And Martin, you can answer.
I mean, I think that is, first of all, it's non-OR to the extreme, but it's also what we do as anesthesiologists to the extreme, being flexible, being adaptable, being able to handle crisis situations. So I think that really is the epitome of our specialty.
Yeah, Martin, have you ever had that opportunity to do something like that?
Thankfully not. I'm very glad that the scariest place I go to is MRI, and I'm quite happy with that.
Yeah, okay. Yeah, I mean, we are almost coming to the end of the time. We just have 1 minute, and may I take this opportunity for 1 minute to thank you, Emily, for your excellent talk and for being part of this discussion. I'm sure we'll be in touch, and we look forward to reading more about all that you have published, because I think you've done a whole lot of wonderful work in the field of anesthesia. And I look forward to hearing more from you. It is quite possible that you may get more invites from us to for talks in the future as well. And meanwhile, enjoy Los Angeles. I love California, and enjoy Los Angeles. It's going to be nice and sunny now there. And Martin, thank you very much for being there and sharing your expertise. And I'm sure there has been much learned in the discussion that you have had today.